See, I think this is broadly true about healthcare in the 21st century. I've just put this slide because just to bring the complexity of what we all do. I think healthcare by far is more complex than any other business or any other activity that goes on in any kind of sphere of industrialization. One, it's a very complex process, highly technology oriented. There was a time 30 years ago, the doctor, it was all driven by the knowledge of the doctor or the wisdom of the doctor. Today, the wisdom has to be highly supplemented by tremendous technology that is needed. High capital cost, which also throws challenges. It has become very skill intensive. I think a good example is in the NABH. Just to transform, our challenge is not resources for NABH. Our challenge is for getting people to adapt to the kind of working of what the NABH expectations are. That is the biggest challenge that we face. I'm sure that's true across the board. And also competition. You know, competition is a reality. It is, a lot of people are fighting for the same pool of people. Insurance is becoming a reality, below poverty line insurance, and in our case we have the CM health insurance scheme. So people are competing for the same resources. So they need not go to one hospital. Just because you're poor, it doesn't mean that you don't have a choice. Today the choices have opened up in many ways, and it has highly become customer driven. Today patient knows what they want. There was a time when the providers were able to dictate what the patient would get. Today, at least in eye care, all of us are aware, patient comes to you and tells us what they need, and they want us to do what they need rather than ask us what is good for them. And also government regulations. I think NABH is going to become mandatory. For CGHS schemes, it's going to become mandatory. So those are government regulations which are coming in, trying to push quality to the forefront. So what we mean by systems is what happens within this box. There was a session here about generating demand, how people would be generated and brought to the doorstep of the hospital. And what happens within this arrow is kind of the productive system. This is what we will be talking. I'll not be talking, sharing a lot on the human resources because that's a session by itself. And as I said earlier, and I'm sure all of you would agree, that the major bottleneck or for any change process is the resistance from individual who are manning stations in the organization. Bottleneck and resource. It's a combination, yes. So the challenges, if you can kind of broadly put it, are all the hospitals have some of these challenges in different forms. One is lack of optimum utilization of resources. Some resources are available but not utilized very well. I think I just saw it from Dr. Junaid's presentation. They had this OP outpatient facility available 24/7. They were using it for 8:1. So that building space was available to be used. So they have found a system where they could get appropriate doctors, nurses and everybody. So that infrastructure was put to good use. Why create a crisis by seeing 2,000 patients within 5 hours? If you can spread it to 10 hours like what they have done, your bottleneck becomes, you kind of de-bottleneck the system in a straightforward way. And the other challenge when we have some of these lack of bottlenecks are poor customer satisfaction, prolonged waiting time. I was very impressed to hear the waiting times. Our waiting times are a little longer. I thought it was far better than others. Our average waiting time is anywhere from 90 minutes, 60 to 90 minutes. And for specialty clinics, it ranges from close to about 120 minutes, 2 hours. And all this leads to poor morale of the team. And as somebody was telling me yesterday, usually the doctors are not the victims of poor morale. You know, the patients don't show the anger towards the doctors. All the anger is shown to the people in the front line who are usually the security or nursing staff or counselors or different levels of staff. So this is Aravind Eye Care System. I'm sure you got an overview yesterday. We have multiple locations. There are two challenges for us. I'm going to touch, I wouldn't say challenge, two issues for us. One is managing the macro system. How do you manage different units in different locations? Probably that is what the policy level challenges would be in a place like Delhi, because they have to plan across the board, different states, different districts. So we have that challenge in a very, very small way because of the number of centers. And the other issue is how do you manage within an individual hospital? So these are two different elements to how we work. So this is a typical volume of work that we do. 2.4 million outpatients annually, 350,000 surgical procedures, of which 50% are free or highly subsidized. When I mean highly subsidized, it's 750 rupees for a cataract surgery, 2,500 or 3,000 for a vitrectomy procedure. Glaucoma surgeries, filtering surgeries are the same at rupees 750. So this is a typical day at Aravind, all hospitals. 6,000 outpatients, of which 90% of our patients are walk-in. We don't have an appointment system. Only for 10% of our patients we have appointment system. We ask them to come for an FFA, we ask them to come for a specific procedure. And we perform about 1,000 to 1,300 surgeries, and also outreach programs you would have heard yesterday, and also 500 to 600 telemedicine consultation. We are about 3,700 employees in the organization, 150 medical officers, and over 200 doctors in training. Just to give you a rough estimate, this is a very critical input. 10% of our manpower is medical doctors, and 90% is support staff. Of the 90%, 60% would be people who are in the medical profession, like mid-level ophthalmic personnel, counselors, and everybody. The other 30% are people who are in administration, security, taking care of everything, accounting and all that, all those things. We find that ratio is very critical for us to be efficient in what we do. Unless each doctor is supported by 6 clinical people and about 3 non-clinical people, they are not as productive as they could be. This is a brief comparison on just to show you the volumes. This is a comparison with the UK. Tamil Nadu population and UK population are pretty much the same, close to 70 million people. And Aravind does about 59% of the surgeries. And the number of ophthalmologists who graduate are about 71%. And the cost for delivering care for UK is about 1.6 billion pounds. And for Aravind-like organization is about close to 14 million pounds. So I think this is I'm not talking about Aravind, but as a country, what we have been able to accomplish, I think the government is spending 4% of our GDP into health. What we have accomplished with that 4% is far significant. I think this total is 4%, which includes all the private spend and everything. Government spends probably 1% of the GDP. In comparison, US spends about 16 to 18% of its GDP on health, which is total. So I think this is a very significant, I think all of us should be really very proud of what our country has been able to give with the limited resources to across the board. Take the immunization program. Many of these programs have been very successful for the resources that have been employed. So when people ask, what does it lead to this cost differential? I'm just sharing this as a background to give you 2 perspectives. One is just to show you the quantum of the work, like 350,000 surgery, how does it get equated, and how does it get equated in terms of financial terms. So these are some of the issues that come up consistently to be able to provide this cost advantage to our patients. Obviously one is efficiency, that's what we are spending time, clinical process, cost of supplies, regulation and defensive medicine. So with that, I'll kind of move into how we run our operations, with this, which is our own arrow box, when a patient comes into the organization. These are some of the broad thought process or paradigm thinking that we would use in being able to manage the organization, patient volume. One is go for standardization across the board. Many of you would have seen our case sheets are pretty much the standard. Wherever you go, whichever hospital you go at Aravind, we use the same format. Even the architecture is standardized. The registration counter is standardized. The software is across the board the same. Imagine if we had different softwares in different places, different case sheets in different places, different architecture in different places. The whole challenge becomes more compounded. So standardization is very important. And also understanding demand variability has been a very important paradigm thinking for us. I'll explain this in a little more detail, but I'll give you a glimpse. Our demand for healthcare is not uniform across the board. In at least if you take eye care, and I know about North India to some extent, is you will have 80% of your eye care happening in 4 months, or 60% happening in 4 months, and 8 months you will do 40%. So that is demand variability. How do we adjust our system real time to be able to handle that demand variability better? Gives you capacity. And also capacity planning. Once you understand demand variability, one could plan capacity. And also to understand capacity planning and demand variability, one has to do forecasting. So you get some anticipated data. Some data that this is what you would see, number of patients you would see tomorrow, day after tomorrow, and the day after. And once you are able to get that data, one is able to schedule. These are the number of doctors who will be there. These are the number of surgeries that we will do. And that helps us plan our inventories a lot better. This is the number of intraocular lenses we need. This is the number of drapes we need, whatever one would need for surgery. And also, because you're building a predictable model, you're able to build a quality assurance system. I know it is a module by itself later in the day, so they'll be dealing a lot more. And motivating employees. These two won't happen without managing these things, is what we have learned over a period of time. When employees come into the organization to work, when patients come into the organization, if you don't give them a familiar ecosystem, an ecosystem that is predictable, then if it's crisis every day, if it is crisis every time, every hour, then people lose morale, both the patients as well as the staff who are handling the patients. So what we have done in standardization is, we have standardized across the board all the outpatient examination procedures, standardized admission procedures. In Aravind, Madurai, we admit about 250 patients on every day, and 250 discharge every day. So the average time, imagine if the whole admission process and discharge process happens in 6 hours in a given day. So within 6 hours, it's about 360 minutes. So we have 1.5 minutes for a patient to admit or discharge. So we need to create a system where we are able to do this within 1.5 minutes if we are not creating a big bottleneck across the system. How have we done? 60% of our surgery is cataract surgery in Aravind. So cataract surgery is a very predictable, very straightforward surgery. There are not very few surprises in those surgeries. 99% of them will get discharged the next day. 1% might have complication, might stay. So what we have done is we have collected money upfront from them. If you have come for an foldable lens, this is your package, say it's 10,000 rupees, you pay the 10,000 rupees. You don't have to pay anything more or less. So within our system, what we have done is we have prepared that way. So there is only one person standing in admission counter. At the same time, he is also taking care of the discharge. So it is not twice they come back to the same system. So 60% of our patients, at least we have taken them away from discharge as a procedure that is needed. It's one-time charge. What we really need to give them at the end of their surgery is a discharge certificate, not a bill that we give. The bill has already been generated and given. And other things are housekeeping, medical records department, and also what we have seen is a transparent price structure, which has really helped. And this is what we see in our day-to-day work. We also are very careful not to increase the price points for customers. Like cataract surgery, it's getting confusing nowadays with cataract surgery. All of you would agree. There are so many choices, so many lenses, so many types of echo. So people have different price points. So we have said we will not have more than 4 to 5 price points at any given point of time. We will not go and complicate it with the patient. So if at all we have to combine, we will combine it with price points. I'll give you an example. Say we do toric IOL at a certain price, 28,000. So we would use that as a benchmark for MICS. If somebody is pushing us to do a micro-incisional cataract surgery with a lens, we would use the same price point for that. We wouldn't create another price point for that. Hope that makes sense, so that you don't have 10 price points. The counselor struggles to explain to the patient, and that was a very important factor for us. So this is what I was telling you about demand variability. Look at year after year after year. I'm sure this is true across the board, across all the organizations that we all come from. Our demand patterns are pretty much the same. I mean, you go in October, all these are Dasara, Diwali, all those days. Our load is definitely a lot lower. Cataract surgery, which is 60% being a planned surgery, Bulk of them in Madurai or Tamil Nadu happens in the summer months. So we kind of peak in March, start the peak in March, and we go till about June, July. And after that it's a lean period. For example, if somebody is planning a CME program or an education program for NABH, we would request the teams to say that don't have it from April to June. Plan all your academic activities starting from August or September through November, so that our demand is low, so we can utilize our extra time that is available for developmental work, so that you don't complicate the system when the system is really busy. Some of the other things that we have done in design, architecture, the building is all services we try to provide in one unit. If somebody goes to unit 1, unit 2, which you have gone through, an average unit sees about 250 patients, of which about 175, 180 patients will be seen, and their whole care would be finished there. And they would be refraction, cataract surgery, some kind of a foreign body or a red eye or whatever, or a review case. So we need to provide everything at that doorstep. And that acts as an area where we segregate patients to go to specialty departments. And we also created something called as, I'll give you the logic a little more detail, which is a below 40 unit in unit 3. Our logic was, when we looked at our volume, we found the waiting time was more. The people who were getting angry were not the older people. The people who were getting angry were the younger people, from 16 to 40, because under 15 they went to pediatric department. They got angry because they had very little illness. They were absolutely fine. They just came for a pair of glasses. They just came for something, LASIK surgery or things like that, or a contact lens. They were very upset if they had been waiting behind a retina patient or a glaucoma patient, because that requires a little more time, and it's time consuming. So we formed a separate unit. I'll give the logic a little bit later. And also clinic layout. We try to use proximity to supporting clinics. Like for example, with a 16 to below 40 unit, we kept the contact lens clinic and an optical shop there. Because these people required a little different optical frames than the people who were a little elderly. Above 40 you need progressives, bifocals, so you get into a different segment. But under 40 it's a different segment. So all these things also helped us to manage that load within that area. So our logic is fairly straightforward. If a patient walks into a system, he should be able to, at least 80% of them should be able to get whatever they need within a few 10 or 20 feet within that unit. They should not be walking from first floor to second floor to third floor, fourth floor to first floor. So that is what we tried to accomplish with this. So how do we go about doing it real time? You've seen a lot of data that we use. I'm sure you've seen this already. We use a lot of data to forecast our patient load. So this is a data we use. Like for example, yesterday, as you can see, June 16th, we expected about 2013 patients. We were close to about 1990 patients or something like that. So we are able to predict very close to plus or minus 2%, because the variability is pretty much the same. Unless we are doing something absolutely wrong, patients have lost faith in us. Pretty much the variability is the same. And you can see the different colors that have been used. Some are green, some are red, some are of a different color, blue. So what that means is green is less than 1200 patients a day, where the volume is very easy for us to manage. Our system is primed to handle 1800. So 1200 is 30% less demand than our capacity, maximum capacity. And you can also see some of those days where we expect very little, the reason is given. Mahavir Jayanti, how much we are expecting. Edir Sevai, which is the Chitrai festival of Madurai, we get a very less volume. But Shubhamurtam is on marriage days, some days we get less volume, like this Monday of May has been a high volume. This helps people to plan in advance on what kind of load they would expect. And also what we have realized is, one is the patient load, but there is a manager who sends every day to some of our senior employees and heads of the units on who are available in those units, so that they don't come in the morning and face a crisis. I don't have a doctor, I'll have to search for a doctor that day. So we have a weekly mail system that goes, and a daily mail that kind of primes people to know that what is the bottleneck. Somebody could have taken leave, Somebody could have had other crises in their family or things like that. All that can be planned for the previous day. And in surgery in the last 1 year, what we have done is, we are also, earlier we never used to give any information on the number of surgeries the next day. In our case, we don't have a unit system. We have people who would go twice a week to the theatre or thrice a week to the theatre. So we send an SMS to all surgeons the previous day by around 6:30 p.m. So they can mentally come prepared. I'm going to operate today till about 12 o'clock. I'm going to operate till about 1 o'clock. I better have a good breakfast and come. I will, so they are mentally prepared to schedule activities. Otherwise they would say, my sons, I have to meet the school teacher. All of them are young mothers or young parents. They'll say, I have to go to the school at around 11 o'clock. So they can't stop the surgery and go. So this way they can plan their day far better, and we have found it reasonably useful. And we also have other kind of tools, ward monitoring tools, consumable planning, and I'm sure outreach you have already seen. The thinking process is, if you can give as much data to prepare them before they come, the providers, the staff, the doctors, the nurses, they are mentally prepared to handle the load far better. And another thing which we have seen, one is at that level of preparing them before. The other thing is real-time monitoring. Crisis happens real-time. Crisis cannot happen in a planned way. When crisis happens when things don't fall apart at that point of time. So we have created a system called clinical management system. Probably some of you have seen it yesterday. Like, what is the average waiting time? How many patients a doctor has seen? How many cases have come to this unit? What percentage have been seen? What percentage are yet to be seen? So what we have done is also provide that screen for the doctor to visualize. Earlier in our system, the administrative team knew how many people came, patients came, because they were registering, they were entering. That data was captured. The nurses knew because we had a computer system in the nursing station. So they knew how many people came. Doctors were unaware of. But doctors could not come out of the OPD every time to look at a system to understand what was the volume. So once we started, the costs of all these monitors have come down significantly too. So adding one of those monitors in each of the doctor's cubicle was not very expensive for us. We also have a OT management software. We are trying to do the same thing that we did in OPD with OT. I'll give you the picture of what we are thinking. We are just starting. A patient has a barcode. Each patient has a barcode. So the moment the barcode is scanned, a screen is there for every surgeon. So the surgeon will get the name of the patient, the eye, the kind of surgery, and the intraocular lens power and the K reading. If we can give this information to a particular doctor real time, and it is not something which they look at the case sheet or something, mistakes can come down very significantly is what we are thinking. And this is some of the reviews that we do. This is post-mortem analysis, how we monitor clinical performance report, OT performance, revenue cycle. We have to be commercially viable, sustainable as an organization. So we can't keep doing everything. We have to be aware of what our revenues are, what our expenditures are. These are some of the ways that we do. So I just wanted to capture some of the themes that I have shared. What we do is do a lot of preparatory work, and this is as Dr. Junaid pointed out, this is a journey. I mean, we will probably try to do something different as we keep going to improve the system. What we have learned so far is adequately preparing the workforce, anticipating, give them appropriate data, forecast the data, and giving them helps a lot in creating a gentle curve in the organization. Not give a very varied curve in the minds of the people. And also real-time monitoring helps us to keep a finger on the system's pulse to make real-time changes and handle crisis. It's not that people are unhappy and we know it after 3 days. If people are unhappy, the report already shows in your system that people are waiting for more than 2 hours. It is logical that when somebody waits more, they are going to be unhappy. And also to look at this data and take decisions consistently is kind of a post-mortem analysis to improve upon how things work. And we have also realized marrying, a lot of times, a lot of focus goes on the clinical system. ignoring the non-clinical system, and we have consistently found taking these two elements together is very critical. And what ties them is all these things: mission, vision, values, culture, strategy. So these two things are very critical, is what we find in our organization. I'm sure in our own deliberations too, bulk of what we are discussing comes under non-clinical. We are not discussing surgery, we are not discussing what kind of surgery. Our challenges are in this domain. Our opportunities are in this domain. But to make it work, we'll have to marry them in an appropriate fashion. And how do we do it real time? We have multiple committees. As was pointed out, we don't have 18 committees because for NABH, but we have about 5 layers of decision making system. We have something called as a department meeting. I'll quickly show this and conclude. So as you can see, we have a department level meeting which discusses departmental issues, parameters, which is kind of headed by the head of the clinic. You know, some decisions are taken at department level, some decisions are taken at patient care improvement, but very few decisions go up to the senior management group, which is kind of the apex decision making body in our organization. So what we have learned over a period of time is break big problems into smaller, easily managed pieces and generate a steady ideas, steady small changes that keeps happening repetitively. And over a period of time, we see that this delivers reasonably good results across the board. I would like to conclude with this quote. I think as was said, in 2008 when they started their journey, it was plans. And I think 19 hospitals had plans. I think that's the number of hospitals that came. But one hospital decided to make it into action and degenerate it into action. And obviously we are all very impressed with what that journey has been. I think that's actually what we are also seeing. Plans at one level, there is a lot of bottlenecks, a lot of opportunities seen, but when you execute, a lot of things look very differently. What we think as challenges are not challenges. What we think as would have been very easy are the most important challenges. That's about how we manage Aravind in a nutshell.